Dear colleagues and friends, it's a great pleasure to welcome you here at the Spine Center in Schönklinik Munich-Harlaching. We will discuss the problems around the treatment of spinal stenosis in the next hour. Dear colleagues, welcome. It's a great pleasure for me to talk to you about a very common topic within spinal surgery, which is the treatment of degenerative lumbar spinal stenosis. We all know that this is a very common type of disease, which is more or less the bread and butter of spine surgeons all around the world. But still there's some controversy about different types of treatments, and I will discuss with you this topic in a minute. Now, when we look at lumbar spinal stenosis, we know that the majority of these patients suffer from degenerative lumbar spinal stenosis. The underlying pathologies are first disc degeneration and then consecutively the degeneration of the facet joint, which comes with a hypertrophy of the facet joint capsule and the yellow ligament, and a step-by-step consecutive circumferential narrowing of the spinal canal, which might be aggravated by disc protrusions or even by disc herniations. Associated pathologies which add on a dynamic component are, for example, degenerative spondylolisthesis, which aggravates the narrowing of the spinal canal, or degenerative lumbar scoliosis, which very often leads to multisegmental changes and clinical symptoms. Now, when we look at the natural course of this type of disease, we know from data from the beginning of the 90s of the last century that more than 80% of the patients, if you do nothing and just observe their symptoms with a follow-up of 4 years, don't change or slightly get worse, and only 15% of the patients show a spontaneous improvement. This has been confirmed by a recent study which has been published this year, which more or less shows that the natural course over 10 years of spinal stenosis is in a way that about 2/3 of the patient still have symptoms or get worse, and about 1/3 of the patient improve over time. So in summary, this means that we deal with a slowly, gradually progressive type of disease. And the question is, how efficient is conservative treatment in order to avoid a worsening of this disease? We know from a randomized controlled trial from Japan from 2005 that even though an in-hospital conservative treatment is done, which included traction, body cast, epidurals, and other types of measures, that with a follow-up of more than 2 years, the outcome was more or less comparable to the natural course. So only about 1/3 of the patient showed a slight improvement. And we know from a meta-analysis which has been published last year, which summarized the results of 21 trials, nearly 2,000 patients, with different types of conservative treatment, that the efficiency of conservative treatment is pretty low, and that less than 1/3 of the patients really can be kept in a tolerable clinical situation with conservative treatment. There's some evidence from the 2000, there was the first study published by Amundsen. It was a randomized controlled trial comparing surgery with conservative treatment. And the result was that after a follow-up of 4 years, about 80% of the surgically treated patients showed a satisfiable result, whereas only 50% of the conservatively treated patients were satisfied with the outcome. And this has been confirmed with the data of the SPORT study published in 2012 by Pearson, with a follow-up of 4 years showing that surgery leads to a significantly better result after a follow-up of 4 years as compared to conservative treatment. Now, to summarize this, we have to realize that when we see a patient with degenerative lumbar spinal stenosis, that basically all these patients have an indication for surgery. The only question is the timing, when should I operate? And from the practical point of view, and you might share my opinion towards this, is that the indication for surgery in this old patient population with an average age of between 70 and 75 years is if these patients suffer from significant pain which cannot be controlled by conservative treatment, if their pain-free or symptom-free walking distance or standing time is reduced, which means at the time point when these patients are endangered to get immobilized, then there's an indication for surgery. And of course, if these patients show motor deficits already at rest, not only after walking or after standing. So in summary, surgery basically is indicated in spinal stenosis if the quality of life of these old patients drops down to a level which is intolerable. We all know that in the treatment of degenerative lumbar spinal stenosis, the symptomatology plays an important role when it comes to the decision which type of treatment is adequate for the patient. And we also know that all these patients who suffer from leg symptoms and claudication also suffer from low back pain. And if we look at the prevalence of low back pain associated to lumbar spinal stenosis, this is very high. We know from the Coflex IDE study from 2012 that of all the patients who needed treatment because of their spinal stenosis, more than 98% of these patients also were suffering from associated and significant back pain for more than 6 months, and more than 87% had this back pain for more than 1 year. And I'm sure it is also your experience that low back pain accompanies these spinal stenosis patients for many years, sometimes for decades. Now, when the question arises, should or must we address low back pain when it comes to surgical treatment, the question has to be answered, which type of back pain are we dealing with? And we know that the majority of these patients suffers from either arthrogenic or discogenic back pain, because this degeneration and degeneration of the facet joint is part of the pathology of lumbar spinal stenosis. And as with the symptoms of the stenosis, also functional components and dynamic components can attribute to this low back pain, such as deformities like degenerative spondylolisthesis or degenerative lumbar scoliosis. They not only aggravate the narrowing of the spinal canal, they also can aggravate the low back pain due to the deformity or due to the change in curvature. Now, if there is significant back pain, the question is what to do. Is it enough to do a decompression? Do we have to add on other types of treatment, such as dynamic or rigid stabilization? And this will be dealt with in the next part. Now I want to discuss with you the surgical options we have for the treatment of degenerative lumbar spinal stenosis. As you know, it's a stage type of surgical treatment which has become popular in the last years. And the question is, what is the least invasive type of treatment? In the last 10 years, interspinous distraction and the implantation of interspinous spaces has been favorized as a first step treatment, especially in cases with early onset spinal stenosis. The first prototype of these types of implants was the X-top implant. With this type of implant, a randomized control trial has been performed in the United States, and the 2-year follow-ups have been published by Zuckerman in 2005. These results show that the implantation of the X-top device, leading to an interspinous distraction, obviously is superior to conservative treatment and leads to success rates of more than 70% as compared to 35% in the conservative group. However, if you look at the improvement of symptoms, they are less than 50% even in the surgically treated group, which is pretty close to a more or less placebo effect. And if we look at other types of interspinous spacers which are performed or implanted as a primary type of treatment for an indirect decompression of the spinal canal, we have to admit that the level of evidence still is pretty low. We have to realize that this type of treatment definitely is a temporary type of treatment to gain time for the patients until they need a open decompression. And if we look at the reoperation rates, they are pretty high, a fact which is definitely under discussion. The most frequent type of treatment which we all perform in our daily practice is probably the direct surgical decompression of the spinal canal. The technique for decompression has considerably changed within the last decades, starting from a complete laminectomy and now ending up with a microsurgical, minimal invasive, unilateral crossover decompression, which has become standard in most of the centers having experience with spinal stenosis. The direct decompression of the spinal canal with a microsurgical technique is certainly the most efficient type of treatment for degenerative lumbar spinal stenosis. The collateral damage has been reduced significantly due to the fact that these procedures are performed in a microsurgical and minimal invasive way, and the technical result as well as the clinical results are good. In 2004, we have published our first experience with 275 patients with this technique, and we could show that the improvement of the walking distance was from 250 meters preoperatively up to more than 5 kilometers at a 2-year follow-up, and the same effect we had looking at the standing time, pain-free preoperative and postoperatively. The advantage of this direct microsurgical decompression is that it can be performed with a minimum of blood loss. The complication rates range below 10%, which is pretty acceptable if you consider that we are treating an old patient population. And in the last years, there has been a number of studies which have published good results with crossover decompression in patients with predominant neurogenic claudication, and the overall results, they range between 73 and more than 90% with follow-ups of up to 5 years. On the other hand, the reoperation rates range between 0.5 and 10 years, also, in my opinion, an acceptable number if you compare this with the reoperation rate with more invasive types of procedures. So the take-home message for direct surgical decompression is that it's definitely an acceptable and well-established type of treatment for patients with dominant neurogenic claudication. The results are good. Usually more than 80% of the good results are achieved within the first 4 months postoperatively. The reoperation rates are pretty low, and true recurrences are extremely rare. Now, looking at the good results of microsurgical direct decompression of the spinal canal for patients with dominant neurogenic claudication, the important question arises: is this maybe also enough for patients who suffer from significant low back pain in addition to their neurogenic claudication? The sports study, which was published in 2012, looked at this specific aspect, and they found that if a decompression is performed in patients who suffer from spinal stenosis and significant back pain preoperatively, the outcome is significantly worse in these patients as compared to those who do not suffer from significant back pain. And similar results have been published already in 2009 by Kleinstück and co-workers. They summarized the data from the Spine Tango with a 1-year follow-up and could find that patients with spinal stenosis suffering from significant low back pain before the operations have a worse outcome looking at the COMI score at 1 year postoperative follow-ups. In our 2004 study, actually we had a similar observation because the improvement of low back pain after mere decompression of the spinal canal was only 50% in the patients we have treated. And this treatment effect even gets worse if the spinal stenosis and the low back pain is associated with a deformity such as a degenerative spondylolisthesis or a degenerative lumbar scoliosis. Toyota published in 2011 a series of patients with 5-year follow-up, and he reported an improvement in patients with spinal stenosis and degenerative spondylo and spinal stenosis and degenerative scoliosis, an improvement rate of between 51 and 64%, which is pretty low as compared to the improvements you can achieve in patients without low back pain. And similar results have been published by Kelleher in 2010. And what he also pointed out was the fact that of those patients who had low back pain, spinal stenosis, and degenerative scoliosis who were operated by a mere decompression, the reoperation rate within the first 5 years was 25%. Now, the summary of all this is that most probably in most of the patients who suffer from significant back pain in association with their spinal stenosis symptoms, the only decompression is probably not the adequate type of treatment to achieve a prolonged and significant good clinical result. Now, after having discussed the clinical effects of indirect and direct decompression in patients with spinal stenosis and low back pain, now the question is, what are we doing with these patients with significant low back pain and spinal stenosis? We all know from our daily practice that the next step definitely is more invasive, and most of these patients, they end up with an indication for a decompression and a spinal fusion. If we look at the evidence level of spinal fusion for degenerative diseases of the lumbar spine, we know that for certain indications it's definitely better than conservative treatment. It's non-superior to total disc replacement, for example, but the Cochrane reviews still report that spinal fusion needs more randomized control trials to really reach an evidence level which is acceptable from the scientific point of view. If we look at the results of fusion following decompression, especially when the spinal stenosis is associated with degenerative spondylo, we have a good evidence that we can reach satisfactory results in most of the patients combining decompressions with a fusion. However, the question is fusion for this old patient population really a type of treatment which we should consider once mere decompression is not enough to treat the low back pain? The more invasive the surgical treatment of spinal stenosis with significant back pain is, the more important is the fact to perform an individual risk-benefit analysis, especially in the patient group suffering from degenerative lumbar spinal stenosis. What characterizes this patient group? These are patients who are usually older than 70 years. In up to 80% of these patients, they suffer from associated comorbidities like cardiovascular problems like diabetes. Most of these patients, they have associated pathologies such as symptomatic degenerative osteoarthritis of the facet joint or degenerative disc disease. Most of these patients, especially the women, have a bad bone quality. And some of these patients, due to the associated comorbidities, they have a reduced life expectancy. So what is the price we pay for a good outcome of a decompression and a fusion in this old patient population? To look at this, we have to look at the complication rates of fusion in this old patient population. There's a number of publications reporting complication rates of decompression and fusion which range between 12 and 100%. This is important to know because fusion up to now was the only option we had, and of course we accepted even higher complication rates to achieve a benefit for the patient. Now, What contributes to these complications? We know that age contributes in general to complications following surgical treatment of the spine. We know that an age of more than 80% bears the risk of 35% to suffer from a major complication. And we know that patients who are older than 69 years have a 9 times higher risk for a major complication from spine surgery as compared to younger patients. And independent risk factors have been identified, and besides the age is the ASAR grading, it's the level of blood loss, which contribute to the rate of complication. In an early publication of Deo from 1993, he already stated that the relative risk of suffering from a complication, of getting a blood transfusion, of having an increased mortality, is increased in patients who get a decompression plus a fusion as compared to patients who only get a decompression. What about mortality? Fortunately, mortality rates in spine surgery are pretty low. A recently published study analyzing more than 1.2 million spine surgeries performed in the US between 1998 and 2008 stated that the overall mortality of spine surgery is 0.2%, which is pretty low. However, also in this study, one of the independent risk factors which have been identified to contribute to a higher mortality was an age of older than 65 years. What other factors influence the mortality rates in spine operations? Smith published in 2012 a paper which analyzed more than 100,000 spine operations, and he could show that fusion and age are risk factors for a higher mortality rate. He could show that in patients who have been treated with a fusion, the mortality rate is 4-fold as compared to those without fusion. And he could also show that in patients who are older than 80 years, the mortality rate is more than 40-fold as compared to patients who are less than 40 years fusion. And the same is true for the fact whether you use implants or not. There's a 3-fold increase of mortality in those patients in which implants were used in spine surgery as compared to those where no implants were used. And looking at general factors such as the ASAR grading, there is a more than 100-fold increase of mortality between ASAR grade 1 and ASAR grade 5. So mortality after fusion in patients with spinal stenosis specifically has been analyzed by papers from Deo in 1993 and Rogers in 2010, and they ended up with mortality rates ranging between 1 and 15%, which is pretty high. And I think this has to be considered, especially in these old patient population. Even though that overall mortality is pretty low, it is increased in patients who are older than 65. It is increased in patients who are treated by a spinal fusion. One of the major goals of each type of spine operation is, of course, to avoid reoperations. And if we look at the reoperation rates following fusion of the lumbar spine, there's growing evidence that the reoperation rates are not as low as they have been expected in the past. So with follow-ups of up to 15 years, the reoperation rates might rise up to 27%. And if we specifically look at reoperation rates following decompression and fusion in spinal stenosis patients within the first 11 years, there's a reoperation rate between 7 and more than 20%. This is something which definitely should be avoided, and it's something which has to be considered in the risk-benefit analysis before deciding for such an operation in a spinal stenosis patients. Now, what contributes to the fact that patients need a reoperation? In a lot of patients, it's the decompensation of the adjacent segment, and we know from biomechanical studies that the more rigid a fusion is, the higher is the load on the adjacent segment, and the higher is the risk that we get a progressive and accelerated decompensation of the adjacent segment. In 2011, SEERS published an annual incidence of adjacent segment degeneration following PLIF and TLIF in patients suffering from spinal stenosis with significant back pain. And this has been confirmed by other studies, for example, by Lenke in 2012 and by the Cochrane Library, which report an annual incidence of adjacent segment degeneration between 0.6 and 3.9%. The risk of suffering from an adjacent segment degeneration increases with age, so patients who are older than 60 years and who also show degeneration of the disc, a degeneration of the facet joint, have a higher risk, which is usually the case in all spinal stenosis patients. And the risk increases as well if the fusion has been performed above L5S1, which is also the case in the majority of the spinal stenosis cases. Now, if we look at radiological changes and compare a progressive degeneration of the adjacent segment radiologically and compare this to the natural course, an interesting paper from 2012 could show that a radiologically relevant adjacent segment degeneration adjacent to a fusion ranges between 12 and 51% in a follow-up between 4 and 12 years. So to summarize all this, I think we have to realize that the results of fusion in spinal stenosis patients are acceptable, however, with a very weak level of evidence. On the other hand, the complication rates are sometimes unacceptably high and have to be considered in the risk-benefit analysis. The reoperation rates can reach up to 27% within the first 15 years, and the annual rate of adjacent segment decompensation can reach up to 3.9% per year. And last not least, the mortality rate is increased in patients receiving a decompression and a fusion suffering from a spinal stenosis if you compare this to the mortality rate of other patients' population or with a mortality rate of spinal surgery in general. Now, if we have patients with a spinal stenosis and significant back pain, what are we doing with these patients? We know on the one hand that mere decompression obviously does not lead to a significant improvement of symptoms in the long run. On the other hand, we know that the combination of decompression and fusion is associated with a high potential of risk. So in the last 10 years, there have been attempts to find a medical or surgical solution which is in between standalone decompression and fusion, and thus so-called dynamic interspinous implants as well as pedicle screw-based dynamic fixation techniques have been evaluated. There's a huge number of studies of clinical case series looking at these patients and the outcomes. But up to now, and this is true for both of these groups of implants, there's no evidence level 1 data suggesting that the treatment with this type of implants is comparable to the treatment with decompression and fusion. Now let me present you now the first randomized control trial which investigated patients with spinal stenosis and significant low back pain. And this is the COFLEX study. It's an FDA controlled IDE study which has been performed in 37 centers in the United States with a 2-year follow-up and a follow-up rate of 96%. Now the goal of the study was to compare two groups of patients. One group who was suffering from spinal stenosis with significant back pain was treated with decompression and fusion, which was the control group. The other group of patients which was suffering from spinal stenosis with significant back pain was treated with decompression and the implantation of a dynamic interlaminar stabilization implant, which is the COFLEX. There were two patient populations. One population was without deformity, and there was a subgroup suffering from spinal stenosis and low back pain with an up to first degree degenerative spondylolisthesis. Included in these studies were patients with a 1 or 2 level spinal stenosis between L1 and L5. They had at least a 6 months conservative trial before the operation, and they were all, by definition, fusion candidates. These patients were divided in the control and index group. Patients with a first degree degenerative spondylolisthesis were included as a subgroup, and the age range of these patients was between 40 and 80 years. All patients with a significant osteopathy, such as osteopenia or osteoporosis, were excluded, as well as were more than double-level stenosis or patients with morbid obesity. Patients who had a previous operation, as well as patients with dynamic instabilities or spondylolisthesis of more than 1 degree were also excluded from the study. The preoperative demographic data were identical in both groups, referring to height, body weight, and age. The data were analyzed from perioperative to a 2-year follow-up. If we look at the perioperative data, we can find the first significant differences. For example, in the Coflex group, the blood loss was 69% less as compared to the fusion group. The time for surgery was 36% less as compared to fusion, and the stay in the hospital was 40% less as compared to fusion. The postoperative evaluation from preoperative to 24 months postoperative showed a significant clinical improvement as referred to the Oswestry Disability Index in both groups, with a slight, however non-significant difference for more improvement in the Coflex group. Interestingly, the Oswestry Disability Index showed a more rapid improvement in the Coflex group, so already after 6 weeks you could see more or less the end result, which was evaluated after 24 months. Looking specifically at the visual analog scale for back pain, because these patients all had significant back pain before the operation, there's a significant improvement in the follow-up in both groups, with no significant difference between fusion and Coflex, but also here we see a trend or a tendency of more improvement in the Coflex group. Looking at the spinal stenosis symptoms and at the Zurich claudication questionnaire, also here we see a significant improvement in both groups, with no difference between Coflex and fusion. The vast majority of the patients were satisfied with the result of surgery. However, here also in the Coflex group, 7% more of the patients were satisfied, and 9% more of the patients as compared to the fusion group would recommend this surgery to another person. Looking at the radiographic postoperative evaluation, one of the interesting questions was, first, can the interlaminar distraction be maintained over 24 months? And for this, the foraminal height was measured in the Coflex group, and it showed that the foraminal height didn't show any changes within the follow-up of 2 years, so the distraction effect was really maintained. One other focus in the radiological evaluation was the adjacent segment, because the hypothesis was that if we do a dynamic fixation of a motion segment, that we don't see the negative effects as with a rigid fixation as referred to the neighboring segments. And here we could see that in a 2-year follow-up, whereas in the Coflex group the range of motion of the adjacent segment remained the same, in the fusion group already after 2 years we saw a 52% increased range of motion in the adjacent segment, suggesting an overload of the adjacent segment. And the same is true for the translation in the adjacent segment. In the Coflex group, no change over 2 years, and in the fusion group, as compared to preoperatively, a 40% increase of translation in the adjacent segment after 2 years. If we specifically look at the subgroup of patients suffering from a degenerative spondylolisthesis of grade 1, the clinical results were identical as compared to those patients without this spondylolisthesis. And if we look at the radiological results, interestingly, there was also in the fusion group a 61% increase of range of motion in the neighboring segment, whereas in the Coflex group there were no changes of range of motion in the neighboring segment. And the same is true for the translation, which increased by 52% in the fusion group, whereas in the Coflex group there were no changes of translational movement in the adjacent segment. And this is a very surprising finding, especially in a group where spondylolisthesis is one of the underlying pathologies. One of the main concerns of implanting a dynamic implant in a motion segment which shows a first-degree spondylolisthesis always was that the translation in this segment might increase due to the interlaminar destruction. However, the Coflex study could show that even in the index segment in a 2-year follow-up there was no significant increase of translation in the patient group suffering from spinal stenosis with low back pain and with first-degree degenerative spondylolisthesis. Looking at postoperative reoperations within the first 2 years, there was no significant difference in the reoperation rate between fusion and the Coflex group. However, if you look at the reoperation in the adjacent segment, this was 3-fold higher in the fusion group as compared to the Coflex group. Now, to summarize all this, what we can say from this study, this is hard evidence level 1 data suggesting that patients suffering from spinal stenosis with significant low back pain, decompression and dynamic interlaminar stabilization with Coflex can achieve comparable or better clinical results as compared to fusion. None of the postoperative outcome parameters did show any inferiority of Coflex. All the outcome parameters either showed non-inferiority or superiority for the Coflex implant. And this has to be seen before the background of less invasiveness and also less costs. And if you look at the follow-up period beyond 2 years, those patients who are now meanwhile in a longer follow-up than 2 years in the fusion group, they again show increasing levels of pain scores, and the significant hypermobility in the neighboring segment also increases. And last not least, the reoperation rate in the adjacent segment in the fusion group is 3-fold as compared to the Coflex group. So in summary, what we can say from this hard data is that if you have a patient with low back pain and spinal stenosis, and if the indication for surgery is there, and if it would be a fusion candidate, consider to perform a decompression with a dynamic stabilization, because there is no evidence from this study that fusion leads to better results as compared to decompression and dynamic stabilization with the Coflex implant. Now, having looked at all the pros and cons, risks and benefits of the different types of surgical procedures for patients suffering from spinal stenosis, how can we end up with a treatment algorithm? And here is a proposal for patients suffering from spinal stenosis with different types of symptoms. So if we see a patient who is mainly suffering from leg symptoms with neurogenic claudication, where low back pain is not in the foreground, where the symptoms are early and not very accentuated, I think these are patients where a conservative treatment can be continued as long as they can manage with their quality of life. If the symptoms lead to an impairment of quality of life, and if the patients get more immobile, or if there's a danger that they lose their mobility, then these are patients who might benefit from an interspinal spacer as a standalone type of treatment or as a temporary treatment. And of course, they will benefit from a microsurgical decompression. The same is true for patients with significant leg symptoms, with mild to moderate and severe spinal stenosis and non-significant back pain. This is the typical group which really benefits from a simple microsurgical decompression. If in the further course of the symptoms back pain comes into foreground, and if these patients do not present with an instability or a spondylolisthesis greater than grade 1 or a degenerative tilt of more than 25-degree Cobb angle, this is the typical group which definitely will benefit from decompression and implantation of an interlaminar dynamic implant like the Coflex. This is a group which we definitely would consider candidates for fusion, and which we have considered as candidates for fusion in the past. But we know it now from the FDA IDE study that these patients significantly benefit from decompression and interlaminar stabilization without having a fusion. And all the other patients who suffer from severe spinal stenosis with significant back pain, with significant deformity or instability, this is still the group where decompression and fusion should be considered as the treatment of choice. Dear colleagues, it was a great pleasure to have you here in Munich and to have your attention. Thank you very much for your time you spent with me. It would be a great pleasure to have you as fellow or visiting surgeon in the future here in the Spine Center at Schön Klinik in Munich, Harlaching. Thank you very much.